Welcome to Pediheart, Pediatric Cardiology Today. My name is Dr. Robert Pass, and I'm the host of this podcast. I am Professor of Pediatrics at the Icahn School of Medicine at Mount Sinai. Thank you for joining me for this week's 308th episode of the podcast. I hope everybody enjoyed last week's Step Back in Time to hear Dr. Tony Pastor speak with us about the importance of lower extremity vascular changes in the Fontan patient and what the implications of these might be. As I mentioned, we spoke with Dr. Tony Pastor, who presently works at Baylor University in Houston, Texas. And for those of you interested in the Fontan operation, and particularly adult congenital heart disease, I'd recommend that you take a listen to last week's episode. As I say most weeks, if you'd like to get in touch with me, my email is easy to remember. It's pediheart@gmail.com. This week, we move on to the world of cardiovascular surgery, and once again, we'll be talking about the Fontan. The title of the work we'll be reviewing is Multiphysiologic State Computational Fluid Dynamics Modeling for Planning Fontan with Interrupted Inferior Vena Cava. The first author of this work is David Hoganson, and the senior author, Peter Hammer, and this work comes to us from Boston Children's Hospital, specifically the Department of Cardiac Surgery and the Department of Cardiology at that institution. When we're done reviewing this paper, Dr. David Hoganson has kindly agreed to speak with us about it. Therefore, let's get straight onto this article and then a conversation with its first author. The work begins with what all pediatric cardiologists know and worry about in their Fontan patients, and that is that the hepatic venous flow is somehow evenly distributed to both pulmonary arteries. The reason for this concern is that there seems to be a hepatic factor of some sort that prevents the development of pulmonary arteriovenous malformations, or AVMs. In a typical Fontan with a single right superior vena cava and ipsilateral IVC, the authors explain that there appears to be a reasonable distribution of hepatic venous factor to both lungs. However, in the setting of an interrupted IVC with azygous continuation as part of heterotaxy polysplenia syndrome, hepatic venous distribution that is even at the time of Fontan can be challenging, and the authors point to prior work studying the development of AVMs in the so-called Kawashima patient, and they reference values of 32 to 85% of these patients developing AVMs, and they imply that this is due to the inequality of flow of hepatic venous blood to the lungs bilaterally. They explain that if a patient with an interrupted IVC has their hepatic venous blood baffled to the pulmonary arteries as part of Fontan completion, most or all of the hepatic venous flow can stream to one lung, enhancing the development of AVMs in the opposite lung. They then explain that it is difficult to predict how the hepatic venous flow will go with multiple inlets and outlets to flow, and they explain that even things like activity level and prandial state can affect hepatic venous flow, and so there can be very wide variability in hepatic venous flow distribution in the Fontan patient. They then explain that prior works have used computational flow dynamic modeling to help plan Fontan completion, even in the setting of an interrupted IVC, and they comment on how these works have shown that the best anatomy and repair may depend on patient-specific anatomy as well as caval inflow rates. Thus, with this as a background, the authors aim to present their experience using computational fluid dynamics to help surgical planning in 4 patients who had an interrupted IVC, and they explain that their workflow was aimed at accurate modeling of the existing anatomy with detailed virtual surgical models for different surgical options, and importantly, in 4 different physiologic conditions to understand the robustness of flow balance over a range of physiological states. The authors then review for us the highly complex manner in which they created computational fluid dynamic models for these 4 patients who had an interrupted IVC with azygous continuation to the SVC. Let me start by saying that I am most certainly not going to adequately explain for you, dear listener, this technique, and so I would as usual recommend that you go to the paper for the details. However, in very general terms, the authors used cardiac MRIs on all 4 patients, allowing for both anatomy and flow data, and also utilized catheterization data for pressures, and then created a 3-dimensional model, and this allowed them to perform virtual surgeries and then test the models in regards to flow. The goal of all of the efforts was basically to achieve a 50-50 flow of hepatic venous flow to each pulmonary artery. The authors do not explain why 50-50 was chosen or utilized, as we really don't definitively know what percentage of hepatic venous flow to a pulmonary artery is needed to avoid or treat AVMs, but this was the goal of the investigators in this work. Blood flow was tested using complex simulations that accounted for blood viscosity and density, as well as specifics of each individual patient, such as the degree of phasic inflow of the IVC and hepatic veins, as measured by CMR, and the individual hepatic veins were included in the three-dimensional model. Streaming of hepatic veins and the potential impact on blood flow distributions were also accounted for. The authors also utilized the pulmonary artery pressure, which was modeled as a static pressure or constant hydraulic resistance, and these data were taken from the catheterization to input into the flow models. One of the most novel aspects of this particular modeling project was the authors' recognition of the impact of anesthesia on blood flows, and how flows measured under anesthesia do not represent normal physiologic states, such as being awake and at rest, being active and exercising, and also after eating or postprandial, where hepatic venous flows can be substantially increased. They show in Figure 2 the different flows predicted in these different states and how they accounted for differences in anesthesia versus normal rest and versus postprandial and exercise. They explain how they modeled hepatic venous flow using massless particles and tracking and quantifying them as they exited the pulmonary artery outlets. The authors also studied power loss in the models with the goal of minimizing energy loss of blood flow. Once they did all of this, and again I've woefully underreported what was likely a Herculean task of doing all of this with biomedical engineers who are co-authors of this work, the investigators then revised the virtual surgeries from the initial ones that the surgeons and cardiologists thought were likely to work to properly distribute flow to ones that improved on flow. And they note, quote, "In all patients, initial surgical reconstruction proposed by the surgeon and cardiologist to balance or rebalance hepatic venous flow to both lungs did not result in an acceptable balance." This resulted in the authors revising the model and then rerunning the new model. And so what happened, or what did they see in the models? Well, first they noticed that if one did a standard Fontan completion, there was basically 100% of hepatic venous flow going to one lung, and the authors show us two patient examples in the paper demonstrating this. They show how different models resulted in different flows, but how in one case, a hepatoazygous shunt achieved a better balance of hepatic venous flow to both lungs, as just an example. The authors then did post-operative validation of these simulations by assessing flows on MRI following the Fontan, and they explained that efforts to quantify hepatic flows on MRI are still investigational, but they can easily measure distribution of all flows in general, and they explained that the model predicted a right-left flow distribution of 51%, 49% respectively, and the actual measured one on the post-op MRIs was fairly close at 49% right, 51% left. Importantly, the authors show how at mean follow-up of 2.5 years, oxygen saturations improved in 3 of the 4 patients, and there was resolution or improvement in AVMs in all 4 Fontan patients, except one patient who was later diagnosed to have Abernethy syndrome after the Fontan, in which one would not expect an improvement, though there was, according to the authors, improvement in the pulmonary vein sats on the left side in that individual patient. In their discussion, the authors explain how this sort of modeling is important to get the optimal surgical approach, and they give an example of one patient who had 4 different surgical approaches and over 80 simulations to determine the best predicted surgical approach. They explain that the great variability in hepatic venous flow amongst patients such as these is such that it is not possible to predict hepatic venous flow without this sort of modeling, given the many factors affecting this, such as the side of the single SVC, or the presence of bilateral SVCs, or the side of the azygous vein, or the angulation of the veins as they enter the pulmonary arteries. And they explain how just doing, for example, a hepatoazygous shunt in all patients may not be a good solution for all patients. They emphasize how their model utilized different physiologic states in optimizing the chosen surgery, and how important this was, in their view, as there is substantial variation in flows depending on the physiologic condition. They mention again the congruence between the predicted and actual pulmonary artery flows on CMR, suggesting the accuracy of these models. In regards to limitations, the authors mention how they did not account for breathing in the models, but plan to in the future, and they also mention how they do not completely account for PVR in Fontan patients, and how future work would focus on measuring the impedance of pulmonary vascular beds in single ventricle patients, and this may have an important impact on Fontan flows. They also mention that the true minimum amount of hepatic flow to a lung to prevent AVMs is not yet known, but they suggest that it is likely in the range of 15 to 20%, based on their reading of the literature. And so they conclude, Single ventricle patients with interrupted IVC have complex physiology, and determining the best surgical approach can be challenging. Patient-specific 3D models, prospective virtual surgery, and computational fluid dynamic analysis over several physiologic states predicts hepatic venous flow distribution to the lungs in order to optimize the surgical plan. This computational workflow may avoid hepatic venous flow maldistribution and the subsequent formation of pulmonary arteriovenous malformations. Well, this is certainly an interesting application of modeling in congenital heart disease, and it is an important one, as I'm sure all listening know of at least one patient in their practice who is troubled by this issue of arteriovenous malformations in the setting of heterotaxy syndrome. The notion that a model can be used to enhance the surgery and improve upon it is really exciting, and certainly is an example of so-called personalized medicine. I do wonder if the 50-50 goal of flow was necessary, and wonder too about the pluses and minuses of achieving that in comparison to the probably higher surgical risks of dissecting out what is likely much more of the chest to achieve these more complex Fontans. I worry also a bit about a possible enhanced thrombosis risk if passive Fontan baffles are being elongated to get blood to a target that is farther than the traditional undersurface of the closest pulmonary artery. Of course, the authors have tried to make up for that by looking at power calculations to determine that there is not adequate loss of power. That said, the potential benefit, if feasible, of this approach is clearly important and could change the course of a Fontan patient's life. At this point, I think it makes sense to move forward to our conversation with the work's first author. Joining us now to discuss this week's work is the work's first author, Dr. David Hoganson. David Hoganson is a graduate of Grove City College for undergraduate work, followed by medical school at Temple University. Following this, he completed surgical residency at Washington University in St. Louis, followed by cardiac surgical training at the same institution. After this, he traveled to Boston Children's Hospital, where he trained in congenital heart surgery. He is assistant professor of surgery at Harvard Medical School and director of the computational 3D visualization program at Children's Hospital Boston. It is a pleasure to welcome Dr. Hoganson to the podcast. Welcome, David, to Pediheart. I'm here now with Dr. David Hoganson of Boston Children's Hospital. David, thank you very much for joining us this week on the podcast.
Yeah, thanks for having me. Excited to be here and chat about how we're approaching complex Fontans.
Yeah, well, very exciting paper. Really, the future is now, I would say. As I was reading your paper, I was wondering to myself just how much hepatic venous blood flow is needed to go to a lung to prevent AVMs. In your work, your team aimed to equalize the flow of the hepatic venous flow, but it seemed that some of the surgical approaches for this were pretty complicated to achieve that goal, or at least more complicated than a traditional, Fontan completion. Do we actually know how much is needed, and can you use this to perhaps maybe, I was thinking, reduce the difficulty of what you're doing at surgery just by achieving an adequate, if not maybe equal, hepatic flow to the PAs?
Yeah, no, those are great questions, and really highlight the balance of what is known and unknown about this complicated problem. In the sense that what we've seen of the patients who develop AVMs typically have either all of the hepatic venous flow going to one lung or virtually all of that flow. So the minimum amount to prevent the formation of AVMs seems quite low. I would say if I had to put a number on it, I would say, anything over about 20% is probably sufficient to prevent the formation of AVMs. But the challenge is we've also seen in these children that when you form AVMs, particularly when you've had long-standing hepatic venous flow maldistribution, and now you're trying to correct or heal those AVMs, that seems to be a little bit dose responsive based on hepatic venous return. So if you're going to heal those AVMs, the best way to do is to shift most of, or if there was a way, almost all the hepatic venous return to that affected lung, and we've seen those AVMs heal quickly when that's able to be done. So it does create a much more complicated scenario to reverse that course than it does to prevent it in the first place.
And most of your patients actually had AVMs already in this series.
Yeah,
right?
Yeah, that's right. And so we've really looked for solutions that we can almost flip that script entirely. And so instead of having 80-20 or 100-0, if we can flip it to 70% or something, if we could, pick a number, the majority of the hepatic venous return going to the affected lung with the AVMs,
Yeah.
and then enough going to the other lung to prevent the formation of AVMs. And we've even had a couple patients, not in this series, but where we've come up with a scenario in which a catheter-based intervention could change that distribution down the line without requiring another intervention. I think when that's possible, that's a really nice solution for the patient. But again, sometimes that's not able to be achieved.
I see. David, the models that you created were designed, obviously, to distribute the best hepatic venous flow to each side. And I'm wondering if you had any thoughts regarding, like, resistance to flow as a result of these somewhat more complex Fontans, and any effect that this approach might have on hepatic venous pressure, which is, of course, another concern. In other words, if you're dividing the flow more precisely in different channels, is it possible that the ultimate venous pressure might be higher? Or am I thinking it wrong? Is it actually the opposite, that it might be lower because as a secondary benefit of sort of better distributing the PA flow?
Yeah, no, you bring up another super important, concept and aspect of this work in trying to optimize these complex Fontans, and that is, what is the pressure drop, or sort of more holistically, what is the energy loss across the entire Fontan pathway, and are we doing something that's increasing the energy loss and thereby increasing the pressure in the IVC and causing abdominal organ, particularly liver issues as a result of that. So that is something that we follow carefully for all the different proposed solutions when we take on one of these complex Fontan patients, to make sure the energy loss across the entire pathway isn't affected in a very adverse way. And I think it's really, we have a couple other papers that are coming out that are highlighting our work on the energy loss and reducing the energy loss, in particular some of these older Fontan patients with either early or at risk for early liver dysfunction. And I think that's a super important aspect of older Fontan care and potentially even intervention that will become, I think, a highlight in the coming years as we come up with ways to manage these Fontans in their later stages that we haven't typically done in the past.
Yeah. And, in similar line, I'm wondering if you had any concerns that by rerouting the hepatic venous flow in sometimes longer connections, for example, you show going to the azygos, that you might actually enhance the chances for Fontan thrombosis, given the relatively sluggish flows that are seen in single ventricle venous anatomy? Or do you think that your power loss assessments that you're doing in the models have allowed you to know that the flows are not substantially affected by these perhaps somewhat more complex baffles?
Yeah, no, certainly Fontan thrombosis is a real challenge in these patients, and part of why we avoid really large Fontan connections when these children are small. So as part of the analysis that we do in these patients, we do look at the shear stress and try to choose conduits and connections that maintain that shear stress within the target venous range. We do have some research funding, and part of our group is looking very closely at trying to model the risk of thrombosis and adding that to the equation. So that will be another feature in the coming years, but we definitely have paid attention to keeping that shear stress within the normal range to avoid those areas of low flow or recirculation, which we know are risk factors for thrombosis. So that's a very important aspect, particularly as you noted, when we're using grafts to make those connections and that artificial material, which is a setup for thrombosis.
Well, now, Dave, I'm going to ask you a non-surgeon's viewpoint question, which is, how easy is it for you to dissect out all the various extra areas that you're using to perform these modified Fontan operations? Practically, how does the time of this operation compare to like a standard, baffle within the heart right up to the ipsilateral PA? I could imagine that there will be resistance by surgeons when they're told they have to start dissecting out, LPAs and things like that. Is this like markedly harder, or how does it compare?
Yeah, I there definitely can be a little bit of a learning curve, but I think it's all within the realm of sort of typical surgical techniques. I think that the one thing that we've learned is one of the value of making these 3D models is we can really plan these operations. And so when you're doing things like connecting the hepatic veins back to the azygos vein, which is near the spine, sometimes it's hard to assess how long should that graft be. But with the 3D models that we make beforehand, that can all be planned out. And so it eliminates that guesswork of operating sort of, deep within the space and trying to make some difficult measurements. So we've been able to sort of mitigate some of those challenges and risks by very meticulous planning, and that has been very, very helpful. So there's a learning curve that that we've been getting over, and I think it's applied. And we've definitely been able to do these type of analysis for other centers, and their surgeons have taken on these operations and done them successfully. So I think this is broadly applicable for these challenging single ventricle patients.
David, as you're talking, I'm thinking about the conversation I had on this podcast a couple of years ago with Rick Mainwaring at Stanford, and he was explaining to me that one of the reasons why surgeons don't feel comfortable doing these complex TET-MAPCA repairs that they do is because they have to operate in what he calls no man's land, areas of the chest that surgeons aren't used to, and he gave as an example like operating behind the esophagus to find MAPCAs.
Sure.
And I was thinking as you were speaking that maybe going back to somebody's azygos near the spine might be another one of those no man's lands that you're not as comfortable, or at least usually operating back near people's spines, I'm guessing.
Yeah. I mean, I think there's definitely an element that comes with it once you've seen and done it once or twice, but it's very achievable, and and the results have been very consistent. And so I think that the at the end of the day, what carries all the weight is what are the hemodynamics going to be, what's the energy loss going to be, what's the fluid distribution going to be, and then how do you achieve that, and and if it takes creating neonominate veins or hepatoazygos shunts to do that in these complex patients, that has really, really paid off. So I think we're just, as a surgeon and as a group, we're thrilled to have these tools so we can stop guessing. And I think that's really the hurdle we've gotten over. And now it's just how do you apply this to more patients? And, I think eventually this kind of analysis will be applied to all Fontan patients. We don't have the bandwidth to do it right now, but we're working towards that. So I think, there's a lot of ways that these methods are going to be able to help, care for these single ventricle patients better in the future.
Well, you cut me off on my last question, which was I was going to ask you, how far off are we for offering this to all Fontan patients? It sounds like we're moving in that direction. Are there any patients other than heterotaxy patients who you think maybe should be the next group that you apply this technology to?
Yeah, for sure. One thing we've learned is bilateral bidirectional Glenn patients are also at very high risk for hepatic venous maldistribution. And that is a group we've really focused on in the last couple of years. And I think anything but a right-sided SVC and a right-sided IVC, those patients are at risk. But I think we're also going to, be able to, as we apply this more to sort of a standard Fontan patient, there are things that we are learning that we're going to be able to optimize those connections. And maybe not as much as we're preventing AVMs, because, as we all know, those patients rarely get AVMs, but they do come back with early elevated, energy loss across their connection and early liver disease.
Yes.
And how do we prevent that? And that's every bit as valuable as preventing AVMs. And so I think that's sort of the next shift of our focus. And I think that's going to be a real opportunity to improve, all these patients. We just need to continue to add the manpower and the efficiency so we can do that in more and more patients.
Well, this is very, very exciting. I think we're going to look back and laugh at how we used to do Fontans without knowing any of this stuff.
Maybe so.
But I guess we're seeing the effects of that right now in our ACHD single ventricle population to some degree.
Yep.
Well, David, I can't thank you enough for joining us this week. For those on the podcast listening to this week, David was like doing a million things today, had a very, very early surgery, and it's really extraordinarily kind of him to give us a few minutes to talk about the paper. I wish to congratulate you and all of the many co-authors you have, and I can't wait to see all the new things you're going to be reviewing and reporting with this new technology. Congratulations and thank you.
Great. Thanks so much for having me. It's been a pleasure.
Great pleasure. Well, as is usually the case with a great guest, there's not a whole lot to say on my end. I thought some of Dr. Hoganson's comments about other uses for this technology to be of interest, especially his comments about patients who have bilateral SVCs and bilateral bidirectional cavopulmonary anastomoses. This really is a situation of the future being now. Imagine being able to apply this technology to most Fontan patients to create the very best Fontan for any given patient, even those with more straightforward anatomy, like patients with tricuspid atresia with ipsilateral SVC and IVC. There are many situations or sequelae of the Fontan that one can imagine might be improved upon by this approach, and I'm sure that, like me, you're excited to see the upcoming results of this work and technique in other single ventricle variant patients. I'm most appreciative to Dr. Hoganson for making time in the middle of what was a very busy day to speak with us this week about this exciting new technology. To conclude this 308th episode of Pediheart, we'll hear an aria from one of the rare operas of Beethoven, and I'm of course speaking of his wondrous opera Fidelio. In this aria entitled In des Lebens, we hear the character Florestan, who is in the depths of a jail, and in this aria he sings of his vision of God and also of his wife, who he prays is coming to save him. And today we hear the wonderful Canadian tenor John Vickers, who was a magnificent dramatic tenor known for the depth of his interpretations, and apparently also for the absolutely gigantic sound he could make in the opera house over any sized orchestra. Thank you very much for joining me for this 308th episode, and thanks so much to our guest. I hope all have a good week ahead.
Ein Engel, zu Freiheit, zu Freiheit, ins himmlische Reich, zu Freiheit, ins himmlische Reich. Hier führt mich zu Freiheit, ins himmlische Reich, zu Freiheit, ins himmlische Reich, ins himmlische Reich.